Stanford University.
Thank you very much, and I was delighted. And Craig, I did not pay any of those people to ask you about the developing world, and I'm delighted that people are already thinking about that, because the focus of the work that I'll be talking about here really is those other 3 billion people in the world who don't know what a sewer is yet, right? So there are a lot of parts in the world that are using radically decentralized. So Craig talks about distributed. I'm focused on radically decentralized water and sanitation technologies and the unique challenges and opportunities that poses for us. And I should also say that as with all of the groups represented today, this is a highly collaborative effort. Some of the folks involved in the developing country work are also involved in other groups. So I have the good fortune to speak with you today, but I hope you know that there's an army behind me. So, there's a lot of press in the news right now around World Water Day, which is on March 22nd. So on March 22nd, do something watery. Because we are about 5 years away from a UN initiative deadline, the Millennium Development Goals, which is a suite of poverty alleviation targets, some of which are related to water and sanitation. And you may hear the statistic that about 800 million, or almost 1 billion people around the world lack access to improved water supply and sanitation. But that's a pretty loose definition, and I would like to broaden that a bit and say that when we're talking about water health and development, we're really focused on about half the world's population that are using what we call non-networked services. So we're used to reticulated systems, pipes that come right into our home that bring fresh water in and remove waste. Non-network systems, by contrast, are decentralized, highly decentralized, so you have point sources for water. Here, boreholes, hand pumps, these types of things. You have latrines, on-site sanitation. And so as I talk through some of the work that we're doing, this is the level of service that I'm thinking about. Now, it's pretty easy to say this is just an economic problem. All countries begin their water and sanitation service delivery systems with non-network solutions. We did. So here's a couple of illustrations from Martin Lossi's great book, The Sanitary City, the United States in the 1800s, fetching water from surface water sources or having it delivered by your local vendor. And here we're talking about the exact same situation in low and middle income countries around the world. So maybe this is just an investment problem. Maybe it's just an economic problem. But I would like to make the argument that, in fact, this isn't going to be changing anytime soon. So a lot of the investment that has gone in under the Millennium Development Goals initiatives are for these non-network solutions, and they're considered solutions. So if I can, so Craig has, I think, given me a hint that, oh no, it does work, okay. So this is looking at 3 developing regions, South Asia, Southeast Asia, and Sub-Saharan Africa. And the data points are 1990 and 2006 for each column. And so what we're seeing is the change in the distribution or the share of populations in these regions that have different kinds of water services. This is just for water here. The yellow are people who have no improved service whatsoever. Those are people fetching for rivers or unprotected wells, etc. This blue, dark blue bar are these non-networked improved water supply services. So countries get credit if they can provide this kind of service to their populations as having improved services. And only down here at the bottom are we looking at network services. So I think for a lot of Americans, when we think, oh, they have access to improved water supply, then they have water supply like I do, network services. But that's not true at all. If you look Sub-Saharan Africa, for example, all of the gains associated with improved access to services between 1990 and 2006 are of this non-network variety. This line is flat. We're not going anywhere. We're not providing reticulated, piped, in-home water services to anyone in Africa, or at least less than 0.5%. There we go. All right. Dramatic pause. So here we go. And I don't even bother in these presentations to put the sanitation slide up because this line for the light blue bar would be less than 1%. So we have very, very few sewers. We have an unprecedented historical experiment going on in the developing world with millions and millions of people living close together on on-site sanitation. So that's going to pose some unique challenges. Okay, so in terms of where this community and water health and development are working, we're really trying to identify places where we can build sincere, meaningful long-term partnerships with institutions that are interested in research on questions that are relevant to a much larger population, the full 3 billion, right? So if you look at this map, this is a little bit different. I think we're used to seeing sort of water scarcity maps or improved water supply maps. This water poverty index was an attempt to take a multidisciplinary look at where in the world we have both physical resource scarcity, institutional capacity issues, and economic access issues, poverty. And so you can see here that as the yellow gets lighter, we're in a worse situation. So this is exactly where we're working, Sub-Saharan Africa and South and Southeast Asia. So what is it about non-network services? So again, you see some lovely latrines here, boreholes, and a rainwater system. So they're unregulated, usually. And at small scales, or when it's a small share of the population that is using this type of system, maybe not a big deal. But when it's the majority of the population in a region or even a country, then this cumulative effect of lots of little unregulated decisions can be really big. They confer investment responsibilities on users. You know, in the United States, we eventually collectively decided to take care of this problem by using general revenues to advance our social goals, societal goals for delivery of clean water and removal of waste. In contrast, when you have these delegated approaches or radically decentralized approaches, it all depends on the users. What can they afford? What's the best they can afford? How motivated are they to improve their services? And I'll talk about this a bit later. If you actually want to see benefits from these kinds of investments in terms of health or poverty alleviation or a variety of other aspirations we might have, it depends a lot on behavior. So the technology is not enough. It requires consistent behavior on the part of a very large number of users. So these are all really unique challenges associated with these radically decentralized solutions. And so we, because we are such a large group and we think about things at different scales, we realize that that's actually what ties us together. That understanding the impacts from one scale to the other and making sure that we're locating the questions, the researchable questions at the right scale, is the benefit of this multidisciplinary community. So at the watershed scale, as I mentioned or alluded to, really important to understand if you have an entire province sinking individual wells, what's happening to water resources at the watershed scale? When you have an entire peri-urban zone of a dense city putting their waste under their house in a so-so quality latrine, what's happening to groundwater quality, right? What's happening to the water that people are using to drink? And also, over time, there's a lot of interest in thinking about the interactions between climate change, land use, and human health. So as just one example, vector-borne diseases, the habitat for things like dengue and malaria are going to change. And they all require a water habitat. And we're very interested in thinking about getting out in front of land use planning and watershed management to look at some of these questions. The service delivery system. So what is the system? If you have these point sources, what are some of the institutional and regulatory arrangements that work, that deliver the societal benefits that you're interested in? And are we using the right technologies? Are they financially sustainable and technically sustainable? I'll give you an example of one of these projects in just a moment. And then again, at the household level, we actually know not very much about the behavioral mechanisms associated with decentralized water and sanitation solutions and how to make sure they're used properly and consistently. And we have an inadequate or incomplete, I would argue, picture of what are the full costs and benefits of these approaches versus other types. So how do we work? This took a while for us to think about this. One of the things that we are interested in is working with partners in the world of practice to collaboratively identify research agendas. And this is difficult. Our practitioner partners have operational problems that they need solved today. We're interested in identifying questions that are relevant for 3 billion people. So when we are working together, we want to identify the things that are really going to leverage not only the situation on the ground with in-depth work, but that would be transferable to a lot of other populations. So I think this probably takes a long time, probably the most. And then we have a process where we engage collaboratively in the research, make sure that we disseminate and vet results locally, but then also organize regional workshops so that learning can happen within regions and scale out and not just up. So I want to give you a couple of examples of this, and I feel, again, I feel a little bit guilty here because I'm going to be talking about 2 projects that I'm deeply involved with just because I know them best, but I'm happy to connect you up. I'm going to sort of list out a few of the things we're working on, and I can connect you with other members of the community if you're interested in them. So let me talk about Tanzania a little bit. Here's an example of a country that is working with very limited resources, right? So out of 171 countries listed by the UN, Tanzania is 161st, toward the bottom, of per capita GDP, so not a lot to work with. They have about half their population with improved water supply. So this is the statistic that the United Nations and the MDGs and the popular press will focus on. But I want you to focus on this for a second. Right? It's only 8% of the population that enjoys the kind of water supply that I enjoy, and that I think most of you enjoy. And those will tend to be in the colonial centers of old cities. And that's it. And so on sanitation, a quarter of the population with improved sanitation, but less than 1% with sewers. So what is the impact of this? Water and sanitation related disease remains a persistent problem in Tanzania. About 1 in 5 kids who dies under the age of 5 is dying from diarrhea, and another 1 in 5 from pneumonia, which is indirectly implicated in water and sanitation. I'll tell you why in a moment. I want to tell you though that this pie chart maps almost precisely to the global picture of child mortality. So throughout the developing world, we're losing about 5,000 kids every day to water and sanitation related disease. And it's about, and all child mortality causes look about like this, right? So again, it's not a Tanzania story, right? It's a much bigger story. And that's only deaths. And I would tell you that we have done a great job at reducing the number of children that die from water sanitation related disease over the past 15 years, largely as a result of curative approaches, oral rehydration therapy, which some of you I'm sure have heard of. It doesn't mean they're not getting sick, it just means that we're not losing them. So I think one thing we don't understand is what is the cost of chronic water and sanitation related illness among these children with respect to cognitive development, long-term productivity, etc. So our partner in Tanzania, our initial partner was the water utility of Dar es Salaam. And they had a very operationally focused dilemma and problem, which is, okay, we have these issues associated with child mortality. In particular, we have cholera every single year during the rainy season. What can we do? And what they did was to focus on this scale. They said, we've got to get households off of the river, right? Stop extracting water from the river and put them on an improved water supply. And they did. They put in these beautiful deep bore wells. They're a little salty, but in general, they're pretty good. I'll show you some data in a second. And storage facilities. And now these households can access safe water within 1,500 meters of the home. The problem was after a couple of years, there have been no changes, virtually no changes in the incidence of cholera or the rate of child mortality associated with water and sanitation-related illness. So they've got a problem. They have an operational problem to justify their existence, right? And we have a much bigger question, which is, what is the real health benefit when we move households from unimproved to improved but non-networked solutions? When do we actually see a gain, and what does the gain look like? So we expanded our partnership. We worked with the Mozambique University of Health and Allied Sciences, and we mounted a piece of work here where we were sampling the stored water in the home, right, the drinking water that's fetched and brought home, the water at the source, and we're also sampling hands. We're also sampling hands. Why? Because all the families that we're interviewing, they have these on-site sanitation facilities, but they're varying quality. So there's a suspicion here that the contamination issues and the exposure routes may have something to do with hands. So here we go. I'll show you this briefly. The good news for the water utilities is that they're doing their jobs. They deliver clean water at the source. This is a measure of fecal contamination of water, and this is just a simple box plot. The center box is showing 50% of the distribution, and then the tails here. And the median is actually here, right? It's hard to see. But basically, in a typical sample from the bore well that the utilities put in, we don't detect any fecal contamination. It's clean. They've done exactly what they promised to do. But the same water, once it comes home and is stored for between a few hours and a couple of days, looks like this. And here's the median value. It's 35 CFU per 100 mil, colony-forming units of E. coli per 100 mils of water. The World Health Organization standard for safe water is 0. It's 0. And there are varying interpretations here, but anything over about 10, we would assume has significant health risks, particularly for children. So the utility's right, but something's wrong. So what's going on? Well, let's look at the hands. Right? So if I came and hand rinsed all of you right now, I think we'd have all zeros. Right? So in typical industrialized country settings, we do not have any fecal contamination on the hands, or very rarely. And that's even true of children. We've done daycare studies in Palo Alto, and we're having a hard time finding one colony-forming unit on kids here. But here, 1,800 for 2 hands, adults. 2,200 for kids, right? So clearly we have an issue. And what I can tell you is that there are two things to think about here. One is the non-network solution provided clean water at a distance. It requires then that we store water until we're ready to drink or cook with it. But it also requires us to carry it. And one jerrycan full of water weighs 44 pounds. So the other thing that we know is until people have water in their yards, they reduce how much they're using for hygiene. Right? So there's sort of a double whammy here that we need to think about. So we worked with our partners and said, all right, well, what is it that we're going to do about this problem? Because you, the water utility, as well as the Ministry of Health, as well as the Mozambique University of Health and Allied Sciences, have run tons of educational programs. And so one of the things that was mentioned with respect to Craig's presentation was education. There have been education programs around hand hygiene in Dar es Salaam for 20 years. And it's not working, it's not taking. And if we just do more of the same, I think that we're ignoring something very real, even about ourselves. We all fail to do healthful behaviors that we know are good for us. I took the elevator this morning instead of the stairs. I ate the donut and not the fruit, right? So it's not a matter of understanding, it's a matter of incentive and getting my attention and keeping my attention. So this is what we thought of to try. Instead of delivering generic health messages, we partnered with our colleagues in the medical school who work on health behavior, and they said, all health behavior theory says, I've got to get the message personal. I have to make it about you, not about them, not about us generically. So what we did was we returned those test results, not water generally, but the water in the bucket behind you, not hands generally, but your hands or your child's hands, and to try to explain what their level of contamination was, what their neighbors was, and then some ordinal ranking here. And also an explanation of what that means in local language, local terms that people would understand. Well, it worked and it worked. What we see here is a plot. This is just looking at the stored drinking water. Okay? The folks who started out with the highest level of contamination in their drinking water got the message, and qualitatively I can tell you there was a big reaction in the homes when we're talking to people. And when we came back, they had dropped down to the level of the control group, which is in gray here, right? So right around 1.5. So they had made a big change. But the folks who got good news, right, started to inch up. Uh-oh. Now look at this for hands. So again, these folks are tracking just with the controls, but folks who we said, you have some of the cleanest hands in the community. They said, oh good, I can focus on other things now. This is one thing I don't need to worry about. And again, this resonates with other health behavior literature. Apparently this is also documented in HIV/AIDS testing, that people relax when they get a negative test. In cholesterol testing, you relax when you see things are getting better. So we have some work to do, but the good news is that in general, the approach seems to get people's attention and it focuses them in a way that generic messaging hasn't. So we're continuing on with this. We actually were very privileged to have a visit. It wasn't our project. Stanford had a visit from the president of Tanzania, President Kikwete, and we had the fortunate opportunity to share a bit of this work with him. We've gone on to write for an NSF grant, and we'll be carrying this out now for a full year in Tanzania, again with these same partners trying to build out on these questions. So I'm going to give you one more quick example of a very different project. So we go from urban, yeah? I've got plenty of time? Okay, slow down. All right. We go from urban sanitation and hygiene to rural water supply. Still in sub-Saharan Africa, but I just want to try to give you a sense of the diversity of issues here that we're looking at. Mozambique. Wow, that certainly should be down here. That was a quiz you all passed. So that was down here. I don't know if Tanzania was in the wrong place as well. I apologize. We do know where we're landing. Okay, so again, very resource constrained, and also a very unique socio-political history in Mozambique, right? So 30 years of war, going from a war against the Portuguese colonists to a civil war. So just a really tough time developing infrastructure in this country for a long time, all the way up until the early 90s. But so we have, again, about half with water supply, and the exact same statistic as Tanzania, about 8% that have that reticulated in-home water supply. Sanitation's looking a little worse, and again, just like Tanzania, nobody with sewers. So the issue that I want to focus your attention on here is a sustainability issue. We've been working with the National Water Agency of Mozambique, and this is a scatter plot of one province in Mozambique called Nampula Province, and you don't need to worry too much about the details. I will just tell you that each point on the map is a water point. If it's in blue, it's working. If it's in red, it's not. So you can get a sense of it right away. We've got about half and half. These are all rural water points, points in areas classified as rural. So we've got 44% functioning and 19% operating with deficiencies, but we've got 35% of them that are completely out of service. And when I say out of service, it's not because it's reached the end of its useful life. It died an early death. And again, if this were just Nampula or were just a Mozambique story, we wouldn't be interested in it. But these statistics track precisely with several continent-wide, sub-Saharan African, continent-wide studies of rural water infrastructure. These things are hard to keep running, okay? So this is the dilemma for the National Water Agency. What can they do to crack this problem? They're focused on a very low level. They have taken up the position that if individual households were more involved in the planning, in the construction, in the maintenance of these water points, that they would last longer. That's a very popular kind of rhetoric in the sector right now. It's been that way for about 15 or 20 years. And so they're doing a lot of things like requiring people to attend training, making them form water committees, all of that sort of thing. There's actually an incredibly limited empirical basis for this policy which affects water resources planning for all of the developing world in rural areas, I can promise you. And the theoretical arguments are also very highly contested. You could make a counter argument that rural people are just like you and me, busy, interested in getting on with their lives and making their children's lives better, and they would rather delegate and pay for that responsibility to be placed in the hands of someone else. And in fact, we have persistent, disappointing results. So something is not quite right, and we need to figure out what it is. Why do we do this? Why do we provide these low levels of service, particularly in rural areas? There is an economy of scale issue to be made in some places, although I can tell you that over the last few years, we've realized that economies of scale in reticulated water supply are not as great as we thought they were, nor in wastewater. So Craig and I are definitely on the same wavelength here about smaller, decentralized. But this is the other reason. It's the first cost problem. So we don't want to be seen to be giving a small share of the population a very high level of service when there are so many that don't have access to service at all. So if you look at the differential here in the cost between, let's look at Africa since we're talking about Africa, a bore well, $20 per capita for a bore well, all in, capital operation, maintenance, everything, versus a standpipe, versus a house tap, right? So you're talking about a factor of 5 to get that water to the yard. And that is really forefront, I think, in the consciousness of water planners in a lot of developing countries. We took the director of the Mozambique National Water Authority Agency through a thought experiment and asked him, okay, these hand pumps are supposed to last for about 12 years. 20 years if they're the really tough kind. How long do you think that they're lasting? And he said, oh, I don't know, maybe about 5 years on average. And if that's true, we don't have to go through all of this, but if that's true, then 80 cents of the dollar is being spent rebuilding something that shouldn't have been broken, instead of expanding services to people who need it. So is this really cheap to have to rebuild, rather than maybe getting up to a higher level of service and seeing where we can go with that in terms of sustainability? So that's the first thing I'll mention. The second thing I'll mention in terms of costs is this. Cost to whom? There are cash costs, cash capital costs. There are also costs to the user. So this is a small set of data comparing households that do have these networked yard taps to those who have non-network taps. So the kind where I'm walking down the lane, I'm going out to a public facility. And the presumption is that this is a very high level of service. It's not walking to the river, it's not walking to a spring. But if you compare, what's the cost to the user? If I can put it in your yard, we've measured that it's going to cost you 1 person day per year to access your water. If I give you this networked, non-networked improved service, it's going to cost you 76 days, 76 person days for your household to obtain the water that you need. And you're going to pay more for it because you're buying it in small volumes. Just like when you buy a bottle of water in 7-Eleven, you pay about the same price as you have to pay your utility for 1,000 liters of that water, right? So it's just about packaging. And in fact, non-network starts to look a whole lot like non-improved, at least in this sample. And it's repeated over and over again. And in fact, it's actually more time because of the queues. People have to stand in line at taps. They don't have to stand in line at rivers. So is this really cheap? Is this really a solution that's benefiting a lot of people? And the last thing I'll point out is with respect to the health benefits. I hope I demonstrated through the Tanzania discussion that the health benefits are also very limited with non-network services unless you get that associated behavior change. And if I could editorialize for 1 minute on that. a lot of energy and intelligence and concern is being put toward point-of-use water treatment, right? So that would be the other way to deal with this. If you have non-network services that are delivering clean water, but you have to keep it clean in the home, what about filters? What about UV? What about coagulants? What about chlorine? Those all work, but I would argue that one, they still have the behavioral aspect that's required for consistent use. Number two, they do nothing to change this equation. People still have to go get the water, they still have to carry it, they will still use limited amounts of it, and now they have the additional burden of having to treat it. So I just wanted to throw that out, because that seems to be very popular right now. So what are we doing in Mozambique? Well, I'm glad David's sitting here because I'm roping him into this project. I'm excited about that. We actually are looking at an experiment in the larger, more dense communities of Nampula province, thinking about this question: when do you graduate? When can a community graduate from a hand pump? And then what happens, right? And if you really cost that out, the full cost, the capital cost of providing a higher level of service, which in this case is probably going to be a solar pumped, small reticulated system, against the benefits for health, the benefits for time savings, the benefits for getting girls back in school, and the long-term poverty alleviation benefits. How does that look? It's never been done, and we are interested in looking at a handful, a few dozen communities in this Nampula province that would fit that bill. So at the same time, we're interested in understanding, again, the sort of watershed effects of all of these micro decisions around sinking of wells and also of on-site sanitation solutions. So it's turning into a very big project. And again, I can't do justice to all of the work that's going on in this community of folks involved in water health and development, but I did want to put this up just to give you a sense of the range of things. We're interested in everything from policy experiments. There's a policy experiment going on right now in Mozambique that the Water Regulatory Authority approached us to be involved with. Water resale. Wastewater irrigation for urban agriculture. So someone asked Craig the question, why isn't this going on? Why don't we do more of it? It's going on elsewhere. But this isn't treated water. This could be raw, undiluted wastewater that's being applied directly to croplands all the way up to treated wastewater. So we're looking at this in a couple of field sites as well. Looking at microfinance, right? If it is just a financing issue, can we think about that? Where's the private sector? What do you do for hand hygiene when water is constrained? And also in the South and Southeast Asia region, sort of a new way of thinking about the arsenic problem, thinking about developing a decision tool that would look at a variety of options for planners and the conditions under which each would be best suited. So again, this not involved in all of these, but a lot. So that's all I had. Thank you so much.
For more, please visit us at stanford.edu.